Greetings and welcome everyone to today's Game Changers seminar. My name is Thokozani Liwewe, a Biosecurity Game Changers Fellowship alumni and one of the coordinators of this seminar series, together with my colleague Sandra Matinyi. Today we are focusing on a very critical topic, advancing the 100 Days Mission for Diagnostics. So over the years, a lot of progress has been made in developing technologies that enable the rapid production of diagnostic tests for emerging pandemic threats. Yet when outbreaks occur, these tests are often not available where and when they are needed most. Led by an excellent panel, today's discussion will explore the challenges affecting diagnostic capacity globally and identify practical policy, scientific, and collaborative solutions to accelerate diagnostic readiness in support of the 100 Days mission. So please feel free to engage and ask questions in the chat. At this point, allow me to hand over to Kelly, my fellow Biosecurity Game Changers Fellowship alumni, who will introduce our distinguished speakers and take us through the rest of today's program. So over to you, Kelly.
Thank you very much, Takazani. Good morning, good afternoon, and good evening to everyone joining us. I'm Kelly Elimia, a biosecurity game changer. Today, we convene under one shared urgency, looking at advancing the 100-day mission for diagnostics from aspiration to action. Diagnostics define whether an outbreak, be it epidemic or pandemic, becomes a story of containment or catastrophe. Our goal today is to explore how we can make those first 100 days count. And discussing this, we have three panelists, Vanessa Moda, John Sands, and Nangwa Hassani. Just a brief introduction before we start the conversation. Vanessa Moda is a diagnostic industry veteran and global health leader dedicated to advancing genomics and diagnostics in pandemic preparedness and infectious disease management. She's currently a senior consultant to diagnostics companies and has spent her career managing diagnostics portfolio for Abbott, Hologic, and Illumina. During that time, she helped to lead responses to many outbreaks, including influenza H1N1, Zika virus, and SARS-CoV-2, popularly referred to as COVID-19 in some communities. In her most recent industry role as Senior Director of Global Health and Infectious Diseases at Illumina, she partnered with multilateral organizations, non-governmental organizations, and the private sector to expand access to pathogen sequencing, positioning Illumina as a founding partner of the Pathogen Genomics Initiative in Africa and Asia. A recognized advocate for integrating pathogen genomics and diagnostics into public health and clinical care pathways, Dr. Moda recently completed a term on the American Society for Microbiology's Global Public Health Programs Committee. She is a founding member of the Alliance to End Biological Threats and remains active on global advisory panels focused on pandemic preparedness and clinical diagnosis. Next is John Sands, my dear colleague during the Biosecurity Game Changers Fellowship. John Sands is an expert in molecular diagnostics and genomics technologies for infectious diseases. He obtained his PhD from the joint Harvard-MIT program in medical engineering and medical physics. During his PhD, John developed novel diagnostics platform based on CRISPR technology, which facilitate fast and accurate viral detection in decentralized settings. Later, as a Biosecurity Game Changers Fellow at Brown's Pandemic Center, and in collaboration with FIND and the IPPX, John co-authored a global diagnostic gap assessment report, which to a large extent will form most of our discussions today. This report identified persistent barrier to diagnostic preparedness globally and provided evidence-based, actionable recommendations to address these barriers. He's currently a Schmidt Science Fellow at Stanford University. Last but not the least, on the panel is Nangwa Hassani. Nagwa Hassani is currently working as a senior advisor, health emergencies in the Center for Health Emergency Strategy and Partnership, UNICEF Supply Division. She has 27 years of professional work experience in infectious diseases in developing countries and health emergencies. She holds a PhD in immunology of infectious diseases and has completed a postdoctoral fellowship in cancer immunotherapy. She had the opportunity to work in diverse settings, including the Ministry of Health and the private sector, in addition to the UN organizations, supporting vaccine research and immunization programs and health emergencies. Her current focus areas is supporting UN context-specific response to emerging and re-emerging public health emergencies with access to medical countermeasures and innovative health technology. So we have a very rich group of experts who will be discussing this topic or this theme on advancing the 100-day mission for diagnostics from aspiration to action. So we start the discussion looking at the vision and urgency for diagnostics. So I will start with John. To have a better foundation for this discussion, could you explain what the 100-day mission is and why diagnostics are such a critical component of achieving the 100-day mission? Over to you, John.
Thanks, Kelly, and thank you everyone for organizing this. I'm very happy to be here. So the 100 Days Mission is a global target to ensure that we have safe and effective medical countermeasures, that's diagnostics, vaccines, therapeutics, and to make sure that they can be developed and scaled within 100 days of detecting a new threat. Now, this global target or agenda or aspirational goal was set by the G7, CEPI, WHO, and other partners. Now, diagnostics are really critical, one of the critical pillars of this 100 Days mission. In a way, they provide like the first line of situational awareness. If you can detect a pathogen, you can't effectively respond. And diagnostics allow us to detect the spillover events early. They guide clinical and public health decisions. They allow us to differentiate between different pathogens that might have similar symptoms. On a more personal level, they also enable informed personal decisions, and they generate data that can drive the development of other medical countermeasures, including vaccines and therapeutics. Now, if we go back to the 100 Days mission itself for diagnostics, that means that we need to have validated tests, whether that is PCR test or LAMP or even like rapid antigen test that you might find in a pharmacy, and ready to deploy globally within 100 days. Yeah, maybe I'll stop there and see if like Vanessa or Nawa want to add anything else.
Okay, before I come to Vanessa or Nagwa, let me just do some follow-up so that the thoughts or the narrative around diagnostics or the certainty pace becomes very complete. When you look back at recent outbreaks, such as COVID-19 to NPOS, especially NPOS in Central Africa and other parts of Africa region, and now the risk of H5N1, from your experience, especially working on the gap assessment, what lessons stand out about how diagnostics have shaped outbreak response globally?
Yeah, thanks, Kelly. Yeah, so first I'll bring up this like diagnostic gap assessment. I'll start by thanking the huge team of people that was in charge of putting this together, especially the team at IPPS, Fine and the Pandemic Center, and especially my co-authors, Kaya and Colleen. I will also thank Nawa as one of the people we interviewed for this process. It was really enlightening. This report essentially found many gaps in the whole diagnostic ecosystem that don't really allow us to get to that day 100 for now. And there's a lot of progress that we have to make in different areas. First, I'll speak about them very like in a high level. The issue here is not a lack of technology, to be completely honest. It's much more about an underfunding and misaligned financial incentives in the diagnostic ecosystem. It's about fragmented regulatory processes and coordination across the whole ecosystem. difficulties with sample access, challenges with context-appropriate manufacturing and supply chain logistics, and so on. And in the report, we provide a lot more nuance about when these different challenges manifest and what we can do about it. Now, to your question on the recent outbreaks, and specifically for COVID-19 and Mpox, we see some related issues, and many of the ones I just mentioned are definitely part of it, but also some outbreak-specific ones. And I would say, like for COVID-19, we saw a lot of innovation flourish and a lot of funding poured into the system, but also a lot of fragmented regulation and coordination issues, as well as like terrible supply chain issues that we saw during the pandemic, and definitely inequitable access to diagnostic tests. It took months for many of these tests to reach many low and middle income countries. And then for Mpox, it revealed persistent challenges with accessing samples, and especially like how to do some of this testing outside of or in different like BL3, that is like high biosegment containment settings. We saw supply chain hurdles and again coordination and like issues with finding specific streams of funding when the money is actually needed. I have some thoughts on H5N1 as well, but Vanessa just put together a beautiful report on H5N1, so maybe Vanessa, you can jump in for that one.
Yes, Vanessa, if you have some thoughts on that.
Sure, I have many thoughts on that. I think H5N1 in particular, we have this opportunity, seeing it progress in animals, to actually act differently. But there are a number of gaps that currently exist. I think if we look at the current landscape of diagnostics, there are not easily distributable diagnostics for H5N1 right now. We know it's coming, we've seen it. We know that it can cause severe illness in humans, and we know it has epidemic and pandemic potential. And so we really need to pull together our regulatory framework to help accelerate the development of diagnostics that can be distributed to all parts of the world, technology that can be transferred for local manufacturing in various parts of the world, and leverage, to John's point, the technology we already have. It's not about necessarily needing to develop something new, but we need to put the market and framework in place to actually support test developers and manufacturers to be able to build ahead of the market. And that's really the challenge, is by the time there is the assurance for a market, for a company, it's too late. It's far too late. These things take time. Currently, in many parts of the world, we would need a emergency use type regulatory framework to accelerate the trials process. And that's not currently in place. So companies are looking at years of validation and clinical trials to be able to launch an H5N1 diagnostic. And I think we all know that when it begins to spread, we're not going to have that kind of time. And so we need to think differently in a number of ways. And I think we have this moment in time when we can act differently and use this as an example of how we can live into the 100-day mission.
All right. Thank you very much, Vanessa. So you already touched on this other part of the discussion on development and regulatory pathways. And you mentioned regulatory challenges, especially when it comes to getting diagnostic products ready for emergency use. And I know this also delay, especially when it comes to time to market for diagnostics. If you could just throw more light on some specific challenges companies face when navigating the regulatory process for new diagnostics.
Sure. I think, the biggest thing to remember is that companies plan years in advance what products they will be developing, and they analyze those markets very carefully. And they want to enter those markets with confidence. They want to know customers will be there. They want to understand the volumes and the pricing in that market. And that is counter to everything about an outbreak and about rapid response. And so there's a real disconnect because it is extraordinarily difficult at a company to prioritize the development of a diagnostic test for an outbreak over something like an oncology test for a market that is stable and that has very high margins and good revenue for the company. because the company is accountable to shareholders and to their board. And so there have to be incentives in place to support companies to do this, because it's to everybody's benefit. And I think companies will at times meet in the middle, and they won't necessarily command the same pricing that they would for other types of tests. But it is essential that financially these companies are supported. And then I think to the other point, the regulatory paths are so onerous in many parts of the world for traditional verification and validation of tests for good reasons. We want highly performing, reliable tests. But in an outbreak or potential outbreak situation, companies need a lot of support to be able to accelerate the development of those tests quickly. And that includes things like having access to specimens. Early in an outbreak, it's incredibly difficult to obtain specimens. I mean, if I went to most companies and asked them to develop an H5N1 test right now, the first thing they would say is, well, how am I going to get those clinical specimens? Where would I find them? And it becomes highly competitive. And so we need to work on an exchange so that there's easy access to well-qualified samples. And this also goes to specimen types. People often don't think about, even for H5N1, we have many different specimen types that have been tested and are relevant clinically, including conjunctival swabs. And these are not typically available samples, and therefore it's very difficult for companies to validate what could be these very important specimen types. And so you can see what really needs to happen is many sectors need to come together to support the diagnostics industry, to help develop target product profiles, for example, that they can build to, so that when they actually put all of this money and time into developing a test, it matters and it works well and it meets the market need. So perhaps others want to comment, but those are a few thoughts about some of the critical things I think we need to put in place.
Yes, thank you very much. Let's just to remind the audience, if you have questions, like specific questions to any of the panelists or general questions, feel free to drop it on the chat box. From time to time, we'll be reviewing the questions and addressing them as we proceed. So Vanessa, before I go to Nagua, you've mentioned a lot of factors influencing whether a company decides to prioritize and develop a new diagnostic product, especially in the context of an outbreak. I'm just wondering, these challenges, are they regionally specific, or is just general from your experience?
In my experience, it's general, and it's first and foremost a timing issue. Outbreaks by definition are unknown. We don't know the magnitude. We don't know the timing of the acceleration. And we don't know the true utility of diagnostics in managing public health when we're very early in an outbreak, unless it's a known pathogen. And so I don't think this is something that transcends borders. And I think while there are regulatory nuances, certainly in different parts of the world, overall, everybody suffers from this financial issue of being able to support adequately the development of these tests.
Thank you very much.
Ellie,
so,
if I can add a couple
yes.
of notes to Vanessa's points. I completely agree with everything Vanessa has said. I will mention two things. One, on the regulatory side, as Vanessa was pointing out as well, I think part of the complication is when you develop a test for a specific state or jurisdiction, moving to even the one next to it can be complicated. So it's not just about how long the process is, but also standardizing some of these processes. So in theory, or at least during an outbreak, you could essentially get an approval for the whole region or even the whole world, ideally. So that if you make a test in the US, it can be used in Canada, it can be used in Mexico, it could be used in Nigeria, anywhere else. Right now, that's not quite how it happens. It's a fairly, I think it's a very actionable point. It's complicated in some ways. There's different regulatory processes, but I think it would be very useful. And then just to comment on one of the last points that Vanessa made as well, I think it's also important to recognize that outbreaks can happen anywhere. But getting a bit practical about currently where diagnostic manufacturing happens, I would say almost 90% of diagnostics for infectious diseases get manufactured in the global north, specifically in North America and Europe primarily. And that poses some challenges when thinking about like which diagnostics to develop, how to deploy them, where do we manufacture them, especially when thinking about outbreaks that are perhaps not at the pandemic scale, but more and have a regional impact.
Thank you very much, John. So I'll come to Nagwa now, and Nagwa, you're free to also respond to some of these comments as you deem fit. But now let's talk about getting this diagnostic test to people. We've talked about the foundation, like the 100-day mission, and of course the regulatory aspect and decisions to produce or prioritize some diagnostic tests, perhaps over others. Now, assuming we have the diagnostic tests ready, let's talk about the logistics, procurement, and delivery. So, Dr. Nagwa Hassani, what are the biggest operational challenges in getting diagnostics from manufacturers to the field or to the end users from your experience?
Thank you very much, Kelly. And can you hear me very well?
Very well.
Thank you. So I guess when I was listening to Vanessa and John, I wanted to react to some of that, but I wanted to go back before that step, because if you buy something, it has to suit you. If it doesn't suit you, then you can't buy it. So UNICEF is working on developing countries, and what we have seen, a lot of the development of diagnostic is driven by the need. Most of the need is happening in developing countries. Look at specific testing. I will take a recent experience from monkeypox. We have a clade 2 monkeypox outbreak in the developed world versus a clade 1b outbreak in the developing countries. So diagnostics we have is clade 2. It's very hard to find a suitable diagnostic for the clades that it is. So yes, there is diagnostics. Even if we won't buy it, it can't suit, because then this is not the right. The second element is the regulatory approval of these type of diagnostic was based on samples and validations that was coming from biobanks that were collecting samples from the specific environment that they were collected. To the contrary, there is already a different immunological and endemicity in the region we are working. And a lot of the countries will come back to tell you, yes, it's nice to have this type of stringent regulatory authority approval, but I don't know if it works for my population. It can cross-react. There is an overlap. So then you need another validation on top of whatever regulatory approval is trying to approve. Third is which level of testing we're going to use this diagnostic on. Are we going to do central lab testing where we're having this high throughput machine? It doesn't exist in many of the countries. And if it exists, it's not calibrated. You need to have many thousand types of other supplies that they have to be there to calibrate the machine, wash the machine, prepare the machine, in addition to electricity, in addition to building up capacity of the lab technician to work. All of these elements is a big struggle. And all of that, what you will decide on the demand forecast that Vanessa was mentioning that manufacturer wanted to know so they can produce. So at the end, everybody will say, well, there is a lot of steps. I have to build up capacity if it's a nucleic acid testing. I have to build up capacity if it's an immunological testing. I need to understand, am I testing at central level, regional level, or primary health care, or even community type testing? How much it will cost me, what is the use case of each diagnostics, how I can build up algorithm, because I can do that much. I can do like reference samples, all the reference sample, I can do it at central level, but I need a lot of rapid diagnostic testing to test at the community level. And then if I want to test at the community level, the sensitivity, specificity would be compromised. So I need a lot of technical support, a lot of policies, a lot of access to surveillance platform. So this is a preventative way. Nobody's looking for a disease that does not exist. So you need first to have the disease and everybody will rush. But the countries are having so much competing priorities that if you ask them, can you start looking for Zika? can you start looking for Rift Valley? Can you start looking for H5N1? They will tell you, well, fine, I have other problem. I have malaria, I have HIV, I have to do measles surveillance, I have polio eradication, I have global commitment. So all of that is the actual operation challenges. So a product is a product that you can supply. You know the cold chain, you know how to transmit it. You know once there goes international travel, but then you can transmit it in the country. But the actual operation challenges is identifying the demand, the actual demand forecasting, then funded that demand, then policy to deploy that product, and then as well community engagement. The people need to be able to say, fine, because they will not go to the clinic to say, can you please test me for a disease that is spreading in Latin America or that is spreading in the Western world. No, I want to be covered for now. So the operational on the logistics, I guess we are transmitting vaccine, we're transmitting a lot of products, and I don't think that there is the operation challenges related to the supply chain itself. It's the way we are looking at diagnostics as a supplement product that we only need it when there is a problem. Over.
Thank you, Nagra. I'll come shortly to the regulatory aspect, especially when it comes to the delivering of diagnostics to the end users. When it comes to operational challenges, do these challenges vary depending on whether there is an outbreak or not, or is just the same regardless of whether there's an outbreak or not?
When there is regular program, remember that people need to see a response to the diagnostic. I will look from not from the manufacturing side, but from the population and community side. If you diagnose me for a disease, I expect the government is going to support for treatment or for vaccination or for something else. So there must be a test and treat or a test and something else that is needed. And so this is where one of the biggest problem is that what is the purpose of diagnostic? What is the use case and what is needed? So during outbreak, we are concerned, but the people themselves, they don't see the way that we see the outbreak. Outside of an outbreak, we have bigger programs that are really doing very well. Malaria diagnosis, we have HIV diagnosis, we have antenatal, neonatal diagnosis. So we have a lot of platform that we are trying to do diagnosis into this because it's programmatic. So you HIV, you test and you give the antiviral. For malaria, you test and you know there is a circulation, so you give the anti-malaria drug, also the preventative measure for vector control. There must be something for that, and also you treat. So I think the problem with the outbreak is actually another element, because a lot of the outbreaks, the population are penalized. They are isolated. They are quarantined. The borders are closed. So this means that if I declare I am positive for a disease, you're going to put me in an isolation center. A lot of people, there is a fear factor, and they are flying. So you need also to understand that we're trying to get adoption of the diagnostic during the outbreak. How can we let people diagnose? I give you two examples during COVID when we were trying to do community, that everybody will test it, testing to go to school, institutional educational institution, or to travel. People will not really want to test, because if I'm going to be positive, I will have to stay out until I have a negative test. So testing was a real problem. And actually, we find it's very difficult to get people tested. In 2016, when we have the Zika outbreak, testing means that there is the association microcephaly in Brazil with a Zika infection. So testing was lead to actually either an abortion, or the mother would expect an anomaly for the child. And these two decisions are very hard. In some countries, abortion was very forbidden. You can't do. Also, having a child with an anomaly is also another thing that you don't know what to do, because what is the treatment? So the operational element that is really rely about what to do with testing and how you can provide testing as a policy to support the community rather than to penalize them.
All right, thank you, Nagwa.
I just had one point regarding regulatory, if you want, and if you have time, we can just address it later.
Yeah, so there is a question from one of the participants online, Ambulai Johnson. So the question is, how can regulatory frameworks be adapted to facilitate quicker access to diagnostics in low-income countries without compromising safety? I think this question is in line with what you've been saying, Nagwa. Or could you briefly respond to this question, please? Thank you.
Yeah, so the regulatory is a big thing, because the one element important of the regulatory is end user monitoring. How can we monitor the performance of the diagnostics in the field? Because the best diagnostics we have, sometimes they perform not as we expect on the field. So I guess the regulatory framework is strengthening the low and middle income countries' national regulatory authorities. This is a process in place. WHO is actually qualifying the national regulatory authority in many of the developing countries. A lot of them had reached now maturity level 3, which is actually meaning capacity to be able to monitor the use of the diagnostic and even ask, this is how the diagnostic I want. Having target product profiles that really address the use cases, clarity about that this is what we need to decide on a treatment, this is what we need to monitor therapeutics, this is what we need to deploy vaccines, and this is the level is accepted. We don't need to have 100% sensitivity and specificity of the diagnostics. We can live with a different quality of products. And then empowering actually the local manufacturing will empower the regulatory frameworks. I think this is if we invest in autonomy and sustainability of the diagnosis, they will be regulated and protected by the people that use them. I don't see you, Kelly, but for the time being, if there is anybody, John or Vanessa, you would like to comment also on that?
Now, maybe I'm going to build on your point, because I completely agree. And another thing that we could do to accelerate it, especially maybe in the African region, as you mentioned, with the different capacity levels for regulatory, there's multiple initiatives, one by the African Medicines Agency, trying to essentially create coordinated dossiers required for different indications, so that you don't have to fully develop and regulate every diagnostic in every single country, especially if they don't have capacity. So in a way, it could just be as simple as saying, okay, for West Africa, we will have like a common mechanism for regulating different diagnostics. The logistics can be tricky in some cases, but effectively saying, like, if we approve a diagnostic for Nigeria, let's say, it could be applied in Ghana as well. That would definitely accelerate deployment of some of these technologies. And second, towards building more capacity, like agencies like the Africa CDC and others are able to provide some technical support and some further like personnel to help with some of this processing. That would be another way to accelerate the regulatory process for many diagnostics.
And I'll just briefly add to that. I mean, I think these points are all extremely relevant. And furthermore, in terms of capacity, there's also the issue of kind of surge capacity itself by regulatory bodies when there is kind of an outbreak or a surge in new diagnostics being developed and submitted to whatever agency it may be. It's not practical for these groups to always be staffed at a level to support that, but there needs to be some mechanism to pull people from other functions, et cetera, to very quickly be able to review these submissions, because that can be another roadblock that we've seen in several parts of the world. It's just simply there aren't the people, even if the regulatory body exists, to actually be able to timely review those submissions.
Thank you, Vanessa. So let's go to cross-cutting issues, especially looking at financing for speed and sustainability. Any of you can respond to this. So in the report authored by John and other colleagues, it is clearly stated that financing is one of the biggest barriers for diagnostic readiness. The question is, why is it so difficult to secure sustainable funding for diagnostics, even when the global risk is so high? For instance, during COVID-19, despite the risk of high case fatality rate, many countries in Africa, they were not really putting substantial funding into it. So the question to any of you is, why is it so difficult to secure sustainable funding for diagnostics?
Well, I can start and then would love to hear from the others. But I think, the cycle of panic and neglect is real. And in spite of ourselves, we just can't seem to break out of it. I think it's just human nature to be resistant to paying for something that's not defined and tangible. And so, as much as people perceive a risk, when it's not real, in that they can see it and see the impact of it, it is very difficult to sequester those funds and prevent them from being used for some other burning fire. There are always more expenses than there are funding and budgets. And so, this is really at the heart of it. And I think we do need to come up with some very innovative tools and mechanisms to be able to sustainably support this by all of the sectors that could be impacted by outbreaks, whether regionally or globally.
Maybe to build on
John?
that point, yeah, I think financing is the really like spooky topic of diagnostics, quite appropriate for Halloween today. I think like diagnostics face like a market paradox of sort. They're very essential for every outbreak and also for routine use in infectious diseases, yet they're fairly unprofitable in the majority of cases, and particularly in between crises. So I think one of the biggest questions is who pays for what and when, and like essentially coordinating all of the potential agents in this space to make a specific diagnostic is what's very challenging. So one of the things we found in the report, and in line with what you were saying, Kelly, effectively every stakeholder we interviewed recognizes financing barriers of one of the top constraints for developing new diagnostics. In the report, we go pretty in depth actually on some of these issues, and we put them in different buckets and provide pretty actionable recommendations for different ones. I won't go into too much detail other than to say that when you get to the specifics, the disease you're working with definitely matters, and we place them into three different buckets. You have a bucket of diseases like Ebola that usually cause outbreaks, but they're not sustained infections throughout the region. And effectively in those, you go in cycles where you need like a huge demand when there's an outbreak and then absolutely no demand in between outbreaks. And it's really hard to predict when the outbreak is here. So financially, that's very hard on anyone planning, from the developers to countries or whatever, to say how many tests do we need and when. Then you have diseases like dengue, which do have sustained infections in a big part of the world, particularly in the tropics. The issue there is a bit more about like purchasing power and sort of like fragmented systems. So there's all the issues we talked about before, like regulatory, like supply chain and others. And then you have like global pathogens such as influenza or COVID-19. And then there's many challenges there, but one of the big ones is inequities. Many of the tests were hoarded by the global north, where like the profits can be higher, you can charge more money in the majority of cases. And thinking about pricing in that context is quite complicated as well. So the bottom line is like who pays for what and how do we make it work?
Yeah, thank you, John. So before I go to Nagua, this is still like a continuation of the financing aspect. So in that report, there was recommendation on diagnostic specific source financing, which you already alluded to, John, portfolio-based manufacturing and blended finance mechanism. So with all of these, from your research, and maybe after you, Vanessa, then we go to Nagua, what innovative financing models could help, or which of the financing model is the best from your assessment?
Well, this is a thorny issue to tackle, but I have some thoughts and have done some prior work in this arena. And I really believe that we're going to need multiple vehicles. I don't think there's one solution. But I think one interesting idea is almost like an insurance pool that blended finance that multiple sectors can pay into to help share the burden of this and de-risk and create a fund that can support some of the activities that we've discussed. I mean, so many other things have been tried and have failed and begin with the best of intent, but I just feel like when it sits on one organization's shoulders, it becomes almost too much of a burden. And I think we lose sight of the fact that everybody benefits from these diagnostics. And therefore, it's kind of a shared responsibility to help support their development.
All right, thank you. So Nagwa, we'll be talking about this sustainable financing for diagnostics. From your experience, how much would you say politics play in determining the outcome of, let's say, preparedness in the context of diagnostics? What is the influence of politics in all of this?
This is a heartbreaking question, of course. I feel, well, I'm standing by the people's side, so I will say it shouldn't, and it has not to. And we are here to do that. This is our role. Our role is to adapt the politics to what is needed by the population. We are the sound of people, so we should not have that. And this is the burden we should take on our hands. But I would like also to react to colleagues, because I think because we have experience once also during Zika. We had funding for products. We did innovative financing. We have advanced procurement. We already de-risked all the manufacturers to start developing the products. We had the product. We tried to deploy the product. But then nobody wants the product because the outbreak is out. Because when you do all of that during the outbreak, every time you started to do all this process, number one, by the time you do a validated product, it's already out of the window of infection. Nobody wants a product. The second, it's again, the political issue kicks in. We need to get the policy in. So we need to lobby to say, if we're going to diagnose, we have to get an informed decision to people so they can take the right decision on their lives and loved ones. So there is a lot of this discussion, but it's out of context now because there is no outbreak. The WHO, for example, the public health emergency of international concern is out. Nobody is really concerned any longer. So you have this sustainability of the pressure. You have a situation that we need to develop diagnostic. Suddenly there is nothing, then you are left alone with that diagnosis. Also, the manufacturers played a role because they did not want to sustain the investments they made. And they said, well, we only can do the diagnostics that we can get profit from. And I think the solution for me is that everybody has to chip in, like what Vanessa said, but also the manufacturing. Because I think diagnostic is a public good. For sure, this is a public good. And they have to be considered as a no regret and a lot of concern. So we have to discuss, and this is our discussion, where are the areas that you still need to make profit, but where are the areas that you need to contribute to the development yourself? And maybe like a multiplex, or maybe this is your portfolio of diagnosis. Maybe this side can be kept for pandemic preparedness of diagnosis because you're having a know-how, or maybe this diagnostic could be done with a local manufacturing. And now the pandemic agreement and the discussion around the pandemic agreement, the pathogen access and benefit sharing, that annexes that are being discussed, this is the type of discussions that is being happening. How can public and private sector cooperate together to find a solution? Because no matter what we have of money is not enough. It's how we use the money and how we benefit from the money. This is what we need to be able to agree on.
Thank you. Yes, Vanessa, please go ahead.
Kelly, just to weigh in quickly, I think just taking that a little bit further, I think one potential solution to the issue you outlined about Zika virus, which is very real, and many companies felt pain from the inventory that they built and then had to scrap. That's difficult to explain in certain boardrooms. But I think minimum volume guarantees are one way to help insulate the companies. Again, the way that those actually get paid for and where that money comes from, I think we have to all come together and figure that out. But that type of a mechanism is one way that we can support the companies to say whether this outbreak continues or not. These entities will support the development or the manufacturing and purchase of this number of diagnostics. And that goes a long way towards being able to prioritize development in the first place, but also to follow through with the actual manufacturing at scale.
Thank you very much. So please, audience, if you have questions, comments, feel free to drop them on the chat or the Q&A box. So there's a comment here from Professor Kelinda Kiley. Incentivizing diagnostics, prophylactics, therapeutics, pandemic preparedness and response means creating motivations, rewards, and enabling mechanisms that encourage government, private sector, researchers, and communities to invest early and act decisively before and during health emergencies. I think this is more like complementary to what we've been discussing so far. There's a question from James Peter Eliku. Sorry if I didn't pronounce the last name well, Eliku. The question is, how can the feasibility assessment of newly developed diagnostic kits in response to an outbreak be conducted for their adaptability for use during the outbreak? I think any of the panelists can respond to this.
Well, I can take a stab, but it's a great question. And especially when we talk about a virus like influenza, we know that virus will change. It changes, sometimes in small little drifts, mutational drifts. Sometimes it's a much larger change. And it is difficult to predict how that's going to happen, but certainly testing against a wide range of strains, trying to anticipate the boundaries of what would be called a positive, what would not be called a positive. I think that's essential. And there needs to be continual support for the understanding of the performance of the diagnostics. And I think this is an expense that people often lose sight of, is you don't just develop and launch a diagnostic and then walk away and do other things. There's constant maintenance of making sure it still performs the way that it did when the outbreak first started. We certainly saw this with COVID-19, but it happens with many other organisms as well. I think the monkeypox example of the different clades is also very relevant. Dengue certainly has that issue. And so there's regional nuance to outbreaks, but organisms obviously change over time, and the performance of those diagnostics can drastically change. And because we can't predict biology, we must have processes in place to continually assess the performance and quickly adapt the tests if necessary. But that also means further support, regulatory and financial, for those changes so that they don't become too burdensome.
Thank you, Vanessa. Just as a follow-up, this is to all the panelists again. Vanessa, you mentioned something about regional nuances when it comes to the response to outbreaks. What role can regional institutions, regional development banks, or new public-private partnerships play in financing diagnostic preparedness?
Maybe I can take a stab and then the other two can chime in. I think there's many things that they could do, and we've mentioned quite a few already. I would say one of them is providing those like blended financing, sometimes the mechanisms to make sure you can like align investments from the private sector as well as government. They could provide technical assistance and capacity, and there's many flavors that could take. It could be like technical assistance and capacity for surveillance. It could be for regulatory processes. It could even be for tech transfer. They could underwrite pool procurement and advance market commitments. So essentially like act as a way to pool all of the demand and provide some guarantees, both for the governments receiving the test as well as the companies producing them. We haven't talked too much about this, but one of the other critical areas would be decentralizing manufacturing and make sure that we can produce fairly locally some of these diagnostic tests. And that will require some tech transfer in the majority of cases. So supporting that technology transfer beyond just like the financial means, but also the whole like support on personnel and know-how would be really helpful. And then like generally speaking, just fund regional data and coordination infrastructure. That would be another way in which they could collaborate or participate in this.
Yeah,
Thanks.
if I may, Kelly, to add also to Jean. Yeah, I think what we do and what we are thinking of is to focus more on how can we integrate the diagnostics for outbreak with the standard platform of surveillance that already exists, because you need to empower the process of diagnosis rather than the diagnostic product itself. By empowering the process of diagnosis, this means that access to samples when you are going to select measles samples, when you go to select polio samples, when you do community surveillance for knocking on the door of people to get the percentage of people that are covered with a specific vaccine. And all of that is we're trying to discuss with the government and with the program, how can we integrate these type of diagnostics, at least a simple diagnosis into as a process, like an assessment, gap analysis, piloting. How can we integrate that into one of the standard routine products that we do? The other thing is the community healthcare worker. There is a big initiative on community healthcare worker that are really big between several organizations. And these community healthcare workers are having access to community. They knock on doors, they can have this access, but they used to give like an analgesic or something and ask if you have a fever or if you have something like this. And by empowering them and empower them technical capacity to be able to do rapid diagnostic testing for a specific type of disease that we have, then you will empower the utilization of diagnostics through process and policy. This will impact the questions that we have, which is, are they suitable? Are they validated for that type of region? Do we have a demand already? Do we know how much is needed? What exactly is needed? What type of which level? All of that is really understanding, and which is data and access and supporting the people. Over to you.
Yeah, thank you. There's another question here from James Peter Eliku. Says, what strategic plans do manufacturers in developed countries have on building capacity of local scientists to produce high quality diagnostics products of technological transfer for a safe world? And I think that's local scientists there, probably referring to scientists in low and middle income countries. So maybe Vanessa, from your experience in the manufacturing sector.
I wish there was a simple singular answer to this question. That would mean success, I think. We're not there yet. I think every manufacturer looks at it differently and has their own motivations. I think some companies are quite good at it. I think they recognize not only the benefit to the region, but also the benefit to the company. I mean, in-region manufacturing gets around a lot of issues of trade compliance and all kinds of other things. It can be very cost effective. But we also know it's better for public health, having the products closer to the people that will use them. Unfortunately, that is not the view that's held by every company. And I think it can be very difficult to set up local manufacturing. And I think over the past few years, coming out of the COVID-19 pandemic, we've seen companies assert that they are going to take a major role in manufacturing in various parts of the world, only to not follow through. Because I think once they realized what it really took, they were not able to carry that out. And so it's clear that this isn't a solved problem, but we have to get there. And the tech transfer piece, I think, is in some ways the easy part, but the will has to be there. And that means a deep understanding of why it's important to do that. So I'll let John and Nagwa comment as well.
Yeah, John, briefly, say 1 minute.
I'll be very fast. No, I completely agree with what you said. I think the majority of these tech transfer and sort of partnerships are built a bit ad hoc. There's not a specific structure for the majority of them. There's many companies that are trying to do it, and it depends on so many parameters, not just like what disease is needed where, but also strategically for the company, does it make sense, what the values and the mission of the company are, and so on.
Thank you. So I think my last question to all the panelists is around, okay, let me frame it like this. If you could name one decisive action for 2026 to move us closer to the 100-day mission for diagnostics specifically, what will it be and who must lead it? Because saying this is what it should be without really specifying an appropriate leadership, I think it will make sense. So What must it be and who will lead it? John?
Yeah, I'll try to be fast. And we've talked about many of the challenges. Everything is very interconnected, but I definitely think we're making progress. And I think any improvement will be tangible and will feel real. So, two things on my side. Sorry to break the rule here. One of them is on the regulatory side. We've talked about these emergency use dossiers that are standardized across jurisdiction, ideally across regions and maybe even larger than that. This is already sort of in progress by WHO, IMDRF, and other partners, and I hope to see this come to fruition soon. And the second one we talked about in emergency situations, there is difficulty in accessing funding. So establishing some sort of a standing working capital fund for diagnostics and other medical countermeasures would be super helpful. I know that the G20, the International Monetary Fund, and other partners are also working to set up something like this. It's a pool of money that different developers and countries could tap into to quickly scale up or even develop diagnostic tests in an emergency. And I think those two are like relatively low-hanging fruits that could have a huge impact.
Thank you. Vanessa?
Wow, you stole my thunder, John. I mean, you're spot on. But I guess maybe another thing I'll say is just better support for manufacturers in the form of standardized target product profiles for outbreaks and specimen exchange, because they sound trivial and they're absolutely not. They can be complete barriers to progress. And so having an organized global framework to get diagnostic manufacturers these things they need to develop effective tests, I think would actually go a long way towards accelerating once the finance mechanisms and regulatory pieces are in place.
Oh, thank you. Last but not the least, Nagra.
Yeah, I think I have to find something new. So I thought maybe the only thing I feel like, and we are doing it, is to bring everybody together for the outbreak for diagnostics. Is there is an interim medical countermeasure network with the WHO that are trying to look at the different medical countermeasure for outbreak response. The diagnostics, there is a diagnostic working stream. So we're trying to bring everybody interested in diagnostic to come to state having a big discussion and alliance and different working group. People look at the upstream, people look at the downstream, people look at the policies, another on the regulatory, private and public, also governments and regional and headquarters. So I guess this is the work that I think if it happens, it will bring all the people that are having their heart looking to bring diagnostic up into the attention and on the level of the political agenda to be supported. This is basically what we need. To be a little bit more ready and even less than 100 days, I hope.
Thank you very much. So thank you, John, Vanessa, and Angwa, for a compelling conversation on advanced diagnostics for the 100-day mission. Today we had 5 many pillars for success, regulatory and operational challenges and how to address them, equitable sample access, modernizing regulation, diversifying manufacturing, and providing better support for manufacturers. Then we also mentioned fit for purpose financing. And just as a concluding remark from Nagwa, adopting a whole of government approach. It's not just restricted to certain institutions or stakeholders. It's everybody coming together to promote the 100 mission for diagnostics. My last take on this is let's transform diagnostics from the weakest to the strongest pillar of pandemic response, so that by the next emergency, whether it's mpox, H5N1, or another SARS-CoV-2, whatever the epidemic or outbreak may be, day one should equal readiness. Finally, please look out for the webinar video on the Pandemic Center platforms and tune into Dinah's podcast, Biosecurity Changing the Game. She has a lot of podcasts on biosecurity, interesting conversation. And lastly, I also will employ you to read the report, Advancing the 100-Day Mission for Diagnostics, 2025 Global Gap Assessment, which is available on the Pandemic Center and IPPS social platform. Thank you all for participating in this discussion, for comments, for questions, and most importantly, for your presence. Special thanks to the IT team and my colleagues, Chokozani and Sandra, for coordinating this discussion. Thank you and enjoy the rest of the day. Bye now.